we can get this party started. Welcome. I will let everyone introduce themselves because if I have to make things up, we're not going to end up in a good place. I'm Holly Credit-Wire, Associate Dean for Admissions and Assessment at Stanford. But more salient to this role is that I've been leading this grant team on implementing competency-based education in emergency medicine since the tail end of 2019. And today we're going to kind of detail where we are with that and where we're going, at least where we think we're going. This is a small group. If people want to interrupt, ask questions, start a dialogue in the middle of this, I am deeply okay with that because honestly, this is more for all of you than it is necessarily for all of us. So there's no disclosures. Abra has no disclosures, even though she wants to have disclosures. So I'm just going to add that.
My cell phone up there. You can text me with things that's not to disclose.
This is going to be kind of like the secrets you send to people online anonymously.
Yeah.
Okay. I'm going to kind of gloss over this part because I really just want to get to the meat of this. But I think we could all agree that education ought to be a continuum, and it frankly isn't. The premise of competency-based education is that it should be, and there are ways to make it such. All these transitions feel like fits and starts. And, you can be driving across these two different bridges in California, both of which are very close to my house. And the scenery looks different, but honestly, it doesn't feel any different driving over them. And that's the way education should be. But it's often like this, which is also that same road. This happens every year without fail. And California doesn't know what to do about it. So they just keep fixing the road. So, this is what we're trying to kind of mitigate and trying to get to this. I want to start with a little bit of a shared mental model, as much as I don't like that term, but just kind of getting everyone on the same page about what competency-based education is. And then we are going to really roll into the nitty-gritty of what we've done. So the fundamentals of CBME really are that education ought to be focused on the needs of patients and populations. And the goal of the trainee should be to attain those desired outcomes so that they can take care of the patients, and that development across the continuum ought to be continuous, seamless. That being said, that's not always the case. And so the way we're going to frame this is really, and again, I shared mental model. There are 5 core components of competency-based education, and we have tackled all 5, and we're going to talk about them kind of in this framework. So it's like a cake. If you don't have all 5 components, it's not competency-based education. And I think we can all collectively agree with that after the Van Mel paper came out. So it's like a cake. If you forget the sugar, it's not a cake. My husband once made a pumpkin cheesecake without sugar. That's a pumpkin-flavored block of cheese. It's disgusting, frankly. And you can put sugar on top of it, and it's still not quite right. So you can't forget one of the components and still have it be CBME. So the way we're going to go about this is really talking about each of these different pieces. And the framework is really just the outcomes that you care about. What is relevant to patients and learners? What is it that you want your learners to be able to achieve and be able to know, do, et cetera, in order to be able to take care of the patients? And that needs to be clearly articulated, transparent. This is not a secret that you're keeping from your learners. And then there's this developmental progression. It doesn't need to be linear. I think we all know it's not. But there is a developmental progression from point A to point B to meet those outcomes. And you're able to kind of guide them along that pathway. And then there's programmatic assessment. I think this is the one people automatically jump to as being the big thing for CBME. And that is assessment using multiple different tools at multiple points in time in multiple contexts to create this full picture of competence. And I liken this to the painting by Georges Seurat, if anybody's seen it. It hangs at the Art Institute in Chicago, of the picnic, where it's all the different dots. And each assessment would be a dot, but the picture of competence is really the whole thing. It's the dog, it's the picnic basket, it's the umbrella, it's the people at the picnic. And being able to see that picture is really what programmatic assessment gives us. And then the things that people often forget. And this is tailored experiences. So this is workplace-based learning that actually facilitates the acquisition of competencies, and it's tailored to the individual, right? Because each of our learners is going to have different things they need to focus on in order to meet those outcomes and grow and develop along that developmental trajectory that they have. And then coaching, and that is coaching in the moment, but also longitudinally looking at that assessment data in order to help our learners, again, grow and develop to meet those outcome competencies. So it all works together, which is why without one, you don't have CBME. So I'm going to have my esteemed panelists introduce themselves because they are going to do a lot of reflecting on what we've done, and you're going to hear from them and kind of the practical experiences that they've had. Ben, where are you?
Hello, I'm Ben Schnapp. I'm the Director of Residency Evaluation and Assessment, incoming PD at the University of Wisconsin.
Laura Hobson.
Sorry.
Booby trap the mic for me. Laura Hobson, I'm the Associate Chair for Education at the University of Michigan. I'm also the President of Board, and I'm not here in that role, but I've been sort of watching this play out both at our own institution as well as nationally and trying to wrestle with some of the challenges of implementation. And I want to very explicitly give a shout out to Will Croft, who's our Associate Program Director at the University of Michigan, who has really been doing all of the heavy lifting.
And we have an open chair if Will would like to come and sit in it.
Unless you have some disclosures.
I was like,
Well, he's walking. I'm Hatter Fan. I'm the program director at Northwestern.
and now you have to introduce yourself.
Will Croft at the University of Michigan. We've been in the simple program with doing CBME for about a year now.
All right, no, you keep that. That's yours. Okay, so, and this is a small microcosm of what is actually a much bigger group of folks now. But now I've dragged everyone in the room here who's part of it up to the front. So, the framework. Let's start there. On the eve of COVID, we all gathered in New York.
March 3rd, March 4th, 2020.
Some people were not allowed to come, and we're online. And some people may or may not have gotten COVID at the meeting. But we all gathered in New York, and we basically sat down and said, what is our framework going to be? We had a set of, I think, 9 people beforehand really just draft what are called entrustable professional activities, but we have rebranded it as everyday physician activities because frankly, that's what they are. It's things that you watch your learners do every single day that you would expect them to be able to do in order to graduate from your program. And we had a small group of people representing, the RC, Milestones 2.0, various different programs, perspectives, et cetera, come together and draft what they thought might work for EPAs. And then we got together in New York for a whole day and really whittled down that list using a Delphi process. And there were lots of rigorous debates and discussions. Small squishy items were thrown. And at the end of the day, we came out, that's true. We came out with 22 EPAs that we could all agree on should be what we're all collectively assessing our residents on. And these are, I'm going to show them to you, but I'm not going to read them all to you, but things that would make sense, right? Lead the resuscitation of a critically ill or injured patient. We do this every day. Creating and prioritizing a differential diagnosis. Applying best evidence to guide patient care. Managing clinical or diagnostic uncertainty when caring for patients. Utilizing observation and reassessment to guide decision-making. You will note some of the things we did. There was a lot of lumping and splitting conversations. We said perform the diagnostic and therapeutic procedures of an emergency physician. We split out in airway management, ultrasound, and procedural sedation as things that are beyond just the procedure itself that we thought were important. Providing palliative and end-of-life care, documenting the encounter, communicating with other healthcare professionals as well as the patient, family, and caregivers. Managing the emergency department flow. These are things that we were like, these are things we absolutely need our trainees to be able to do by the time they graduate from residency. And at the end of the day, we sat down and said, okay, how are we going to assess this? If we need to have some sort of supervision scale, what is that going to look like? And we looked at all of them. And for various reasons, we either liked or didn't like different parts of each of them. And what we came to decide was, we're like, okay, it actually makes more sense for us at the end of a shift to say, what did we actually need to do? But the Ottawa entrustment scale really didn't work for us. And we said, we're never not there. How do we adapt this to actually work for us? So the last two anchors you'll note are very different. So I needed to be there, but did not help. So this is the, you sat in the back of the trauma bay and you were like, I'm here. I can whisper sweet nothings in your ear if you're, getting off course. Um, but you may or may not need me. And then I didn't need to be there at all. I could have been in the cafeteria, but clearly I wasn't because we need to bill for this. So, right? And so this is what we came up with. And I would love to hear, kind of from the perspective of everyone in the group. We took these back to faculty, to residents, to patients. They were iteratively edited. Kind of what your experience has been with using these so far.
I'm happy to start. I think we've run into maybe a couple of issues with this. Maybe things that you might predict. One of which is sort of grade inflation, despite the fact that these are not grades. People like to give, high anchors. They like to tell people that they're doing a good job. So, we had to have a little chat with the faculty when, our data was coming back saying that, a large percentage of our interns I needed to be there, but I didn't help with things like procedural sedation. It's like, no, I don't think so. You needed to be there and you definitely helped. If not, I'm very concerned about this and we need to have a different conversation. The other thing that I feel like we've run into a little bit is almost what I consider to be the failure of imagination problem of really the problem around anchor number 4, right? I think people have a hard time being like, they understand what I helped a little is. Many people are good at helping a little. And they understand what I didn't need to help at all is, because they weren't there. They were not, doing anything in the room with the patient who's getting sutured. They were maybe they were in the cafeteria. But I think, I needed to be there, but I didn't help. I don't know that people necessarily have a great grasp around, they can't necessarily use their imagination in that way. So we've had some questions and some challenges around getting faculty to wrap their heads around that one in particular.
I would say that we've had different challenges because for us, number 5 has raised a lot more problems where people say I didn't need to be there at all, because we have a lot of senior faculty who push back on that and say, whoa, 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 from a medical legal perspective, there's no way that I don't need to be there. Why is that even an option that we can choose from? And we sort of have to think about this more from an entrustment perspective. Would the resident actually have required you to be in the room, rather than thinking about it from that medical legal perspective? The other thing that's different from Ben's experience is that I think we had great deflation. When we looked at our first round of this, initially we had a really high trend in terms of the numerical ratings that our residents had in previous years. And then when we switched to this system, I found that we had a pretty large decrement in the values that people were receiving, especially on the senior resident side. And it was a little bit confusing for us because we had to then take those new numbers and from this completely new system and then sort of titrate based on the commentary that we received. And so we would have lower numerical values, and we'd look at that and say, well, yeah, but this person seems to be performing just fine. So I think people are still not interpreting this in the way that we expect them to. And so we have to take what they actually said about the person and then use that to then dial it up another notch or two. And so it's been interesting. We've had such disparate experiences based on basically the cultures of our own shops being slightly different when we started.
Yeah, and I guess on a totally different set of challenges. So this scale is actually the same scale that our medical school uses, so our faculty is actually very well aware of it. Obviously, the skills that we are entrusting the fourth-year medical students with are very different than the residents, and a fourth-year student, for most of their EPAs, should be at the higher end of the scale. So I think initially there was a little bit of a learning curve in grade inflation, but I think the ease of using this scale and having things that are very sort of obvious and objective and easy to watch has made our faculty far more comfortable with actually putting entrustment decisions down. Our old assessment system was very much gestalt, what did they do well? What would you give them advice to improve? And I think the activation energy of that is really, really high. So for the faculty to be able to pick something and say, I saw that today, and feel much more confident in using this scale and being able to assign an entrustment decision is great. And because we have so many more data points, I think everyone feels like each individual data point is much lower stakes. So they are less inclined to try to be nice because it's not their single thing that's going to, tank this resident on this particular EPA. So I think for us, it was an easier transition because the faculty were used to it. It was sort of reverting to a mean that they were aware of. And like, honestly, our biggest challenge has been getting the residents to be the ones to initiate the conversation. The faculty have been very excited to use the app and to, select EPAs and all those sort of things. But now it's this huge lift to change the culture so that the residents are like, oh, actually, I did these things. You watched me do these things. Please, fill out an assessment on these EPAs. And that we have not quite been able to change the culture again. We're on year 2 of our implementation. And I do want to say, we're a very Midwestern crew that's up here. I don't think that should sway any opinions. It's not just that there's Midwestern nice folks that are doing this. But it's kind of funny that we're all very tightly geographically clustered.
You guys were the ones who were available. Yeah, that being said, you look at our other sites. It's Vanderbilt, University of Pennsylvania in town, Stanford, and OHSU out in Portland. And then we've had sites that have been added later. And Elise, there's a likelihood I may drag you up here at some point. Advocate Christ, UC Davis, Two Spirit down in Phoenix. We've had a lot of programs kind of join up and contribute as well. And if I forgot anyone, I'm sorry. Oh, University of Missouri. Another thing we actually sat down and did was we put the EPA, and I want to come back actually. So themes that I'm going to pull out. Faculty development is going to be very different depending upon context, but it is incredibly important. And I think iterative faculty development, a lot of what we've had success with is kind of these small nuggets and reminders over the course of time, because you'll see faculty change their behaviors, and then they'll do something completely different that you're like, wait, not quite that. Or they'll tail off and you'll be like, what do I need to do to re-incentivize them to engage? And then we have seen at different programs where this is almost exclusively resident driven versus exclusively faculty driven versus somewhere in between. And all of that is okay. It's just generally what works for you and your context. There are no rules about how it has to work. So the other thing that we noticed is some of our programs were like, it's really hard to have all 22 EPAs available all the time. Or is there a way we can kind of put these into buckets? And so we actually did another subsequent Delphi to sort them into kind of what's that transition to discipline, early intern year? What do you expect them to do first? What's the core of emergency medicine? The things that we need them to do to be able to take care of their, individual patients, their, small panel of patients. And then what's that transition to practice? What's the higher order departmental management, supervision, that kind of stuff. And I will say that it's very interesting, and we actually do have a pretty good split up here of programs that do and don't use that. So for example, at Stanford, for the vast majority of our faculty, they use all of them all the time. But, and Ben, I'm going to pick on you here. I mean, you guys were the ones who really asked for this. And how has that worked out?
I think it's been helpful to us for sure. I think what we were finding was, even with faculty being incentivized with, the end of year comp plan with a certain amount of, these that they have to participate in, it just, we weren't getting great high volume data for the EPAs that we were most interested in, for example, for our interns, because people might fill out something, they maybe had a end of life case with an intern. Okay, that's great, that your intern needed a lot of help providing end-of-life care, but, I probably could have guessed that. That's probably not what I'm most interested in finding out about my intern and where they are along the process. I'm guessing most, if not all of them, are going to need a lot of help providing, end-of-life care. So this was sort of an effort for us to sort of concentrate the EPAs while not being sort of heavy-handed about it, but just offering a suggestion to faculty. Hey, by the way, if you're looking for some to fill out, this is what we're kind of most interested in. But hey, let's say you had a great, procedural sedation. Let's say you had a great end-of-life case. Go nuts. If that's what you want to fill out, if that's what you want to talk about, if that's the way your conversation was, we're not putting up barriers to it. It's more we're offering a nudge, we're offering a suggestion, and we do feel like, at least for us, it's been helpful in terms of getting us what we're looking for there.
We have not been using any sort of tiered system, but Will's data does suggest that we all as faculty have, and probably the residents have our preferred EPAs that tend to be used much more often. I think one of the most interesting things has been the richness of the qualitative feedback that this has helped engender. And we generally find that people may riff off on their lead a resuscitation team with an EPA score, but then say the narrative review tends to divulge into team communication, patient and family communication, diagnostic reasoning, all through in the same text. So that qualitative data ends up being incredibly rich in this system and a great source for feedback, as well as to identify challenges and areas really of strength.
And I'll mention regarding the tiers that for us, we chose not to use them partially because at the end of the day, you have to report milestones about all of your learners. And you have to figure out how to translate some of the EPAs into each of the milestones. The system that we use does that sort of automatically, but there's still a fair amount of like mental energy that goes into it from each APD's perspective based on the resident they're working with. And we wanted to make sure that we had the full panoply of data available to us, and so we didn't want to restrict people by telling them what they should or shouldn't use based on the level of training of the trainee. And even with that, we found that we still did occasionally have some holes in terms of like lining up the data that we wanted in order to assign milestones for specific items. And so we'd have to like go back and occasionally I would just ask somebody, hey, did you observe this specific thing about this resident? Because I just need a little bit more information about them. And my concern in using a tiered system would be that I'd be setting people up to not give me all the data that I wanted about people. And as Laura pointed out, like there are some things like flow in the emergency department or resuscitation that everybody just always wants to talk about. And you can learn a lot about a person like across most of the milestone spectrum just by using those couple of EPAs. You don't quite get everything. Like PBLIs, like that's SBP stuff doesn't cover quite as well in those. And so you have to have a number of other things in order to round that out. So I think the tier system is a powerful way to redirect people's thinking, but it did not for us capture all the data that we wanted it to.
So Will's getting ahead of me, which is great. I will say, and then this kind of goes back to the faculty development piece again, is really figuring out, it's not just the assessment piece. Using the EPAs actually gives you pretty rich program evaluation data because you're able to identify if there are gaps in your assessment practices where your residents aren't having the opportunity to be assessed on certain things. So we noticed our palliative care EPA and our procedural sedation EPA were pretty low. We're like, they're definitely doing end of life care. They're definitely doing it. I just don't think people are assessing it. Our procedural sedation, our residents don't do a lot of them. And so I was like, that's on us. We need to get them the opportunities to actually do procedural sedation. But then we basically just said, hey, the EPA of the month is palliative care. Like, if you see it, make sure you fill out an EPA so we can boost our numbers on this EPA because we're noticing that we have holes. So again, another plug. One of our big lessons learned is really figuring out what faculty development looks like, particularly in different contexts, and where we need to put our efforts. So the milestone piece, because I can hear without anybody actually saying it, but what about the milestones? So EPAs encompass multiple domains of competence, so all the kind of big bucket competency, patient care, systems-based practice, et cetera, and each of those have their competencies and their associated milestones. So, and this group can throw vegetables at me for days, probably over this. We went through a whole milestone mapping process where we basically sat down, and this happened over the course of probably like 9 months, and said which subcompetencies map to each of the EPAs. Yep. And then from there, after a couple of rounds of narrowing all those down, we said, if they're fully entrustable in the EPA for each of the subcompetencies you said mapped to this, if they're fully entrustable, what's the maximal milestone level they could achieve? And then we mapped backwards from there. So if you look at the whole thing, it is this giant Excel spreadsheet that gives you a full milestone map where you can map for all of the EPAs. So lead the resuscitation of critically ill or injured patient, multiple patient care subcompetencies, medical knowledge, communication, but they all mapped different things. And this is just the subcompetency map. And again, slides are in the app. You can look at this. And this paper is probably our next one. I need to finish editing that. But they all mapped all these different milestones. And yes, If you have your EPA spray chart of all of the different EPAs they've had for the last 6 months, you can get a milestone printout of where they would be and then edit that from there based on kind of the comments that you see. It's usually a little bit up or a little bit down, but it's pretty accurate. All right, let's get into assessment. So this looks a little bit different for different programs, but the whole premise behind programmatic assessment is, again, that you have direct observation using the EPAs, but also there's multi-source feedback. There's SIM, procedural skills, EHR data, standardized patients, the in-training exam, QI projects, quality project. Every program is going to have things that are important to you to make decisions about whether your residents are ready to progress or not yet, how you make those decisions, and how you decide they're ready to graduate. And all of this information gets fed into your competency committee. So a word about entrustment. There's the ad hoc piece, which you have your frontline faculty do. And this group has talked a fair bit about that already. We use, in most of our contexts, the simple app. However, we still have people using homegrown apps, Qualtrics. I think somebody's on RedCap. You guys used paper for a long time.
Still using paper.
A little bit. Mostly using simple, but yes, a little bit of paper. Whatever works to get the data. I have no qualms about saying that. But this is really what it looks like. And yes, simple is trolling me with a Mets fan as the baseline person. But you can pick a bunch of different EPAs and you go through and it's exactly what we're talking about. So it's the supervision scale I already showed you. How many times did you see that before providing your rating? And we're probably going to add some more contextual things in, such as like age range of the patient, neonate, peds, adult, really to kind of help drive, decisions around the PD attestation and things like that. But then it's also the feedback. And as Laura alluded to, it's pretty rich. We used to just have one box that said, what goals do you have for them to make further progress on the CPA? And the resident said, wait a second, I swear I did something right on this shift. You should tell me what that was. So we said, what went well today that this trainee should continue to do to reinforce the good stuff? And then what goals do you have for them to make further progress on this EPA during their next shift? We always ask them to be specific. For the most part, we get pretty good information. Thoughts on this from the group, in addition to what you've already said?
Good.
I find that I have some faculty members who will only type in one box because they only want one box. They want to just write things one time. And so rather than giving feedback on what people did well separately from what they have room to improve on, they'll just put it all in one place and then say, see other box. So it does come out a little bit convoluted when we have to generate spreadsheets that have all the data for us. And I look forward to data visualization tools that will make it easier for us to see these things simply. But
That's at the end of the presentation, Will.
okay. But it does, it clouds things a little bit. And again, it just speaks to the fact there is still a fair amount of human interpretation that's going to be required for any system that you implement.
Yeah, so going back, my faculty are creatures of habit. So our old assessment system was the 2 boxes. So everyone has fallen well into line with that, in this very similar wording, honestly. So that part has been okay. I will say that the biggest complaint that my faculty have, because they are also procrastinators, is you can only backdate the assessments by like 4 days. And so I have a lot of things that they're like typing, they're like, this actually happened like a week and a half ago, I didn't get around to doing it until now. But that is like the #1 complaint I get from my faculty regarding the app itself.
I will say that I have reverted to just telling my faculty, just date it today. And then put in the comments when it actually happened. However, best practices are obviously to do it within a week, which is why the app will expire your assessments if the residents send them to you after 7 days. And you can only backdate them for 4.
And I feel like we've been hammering the faculty development theme, but I feel like this is another one for us. Despite what the prompts say, how can the resident make more progress in this area? We get people writing things like "great job" because that's what they feel in their heart, and I'm happy for them. It has nothing to do with helping the residents grow or progress on the EPAs. So periodic reminders that yes, please write both helpful things and relevant things in the box, and not leave the box blank or write something that doesn't really help anybody in there.
Initiates this? Is this resident initiated from at the end of the shift? Faculty?
It can be both.
That's a great question.
Yes, this time of year, right? So suddenly, the resident who hasn't requested anything, I'm getting 4 evals on different EPAs from this one resident. And I'm like, I haven't ordered you.
I would love that. I would
Yeah, please.
send us the residents that want the evals filled out. No, ours is a very faculty-driven system because it kind of has been for a long time. We're in the same boat as Abra of like I would love to help change the culture and have people bringing these or sending them to ours. But yeah, the residents can pick an EPA, send it to you in this app, and it shows up in your little inbox, and you can do it. But for the most part, at least for us, it's the faculty sort of initiating this and assigning the EPA level, and then it shows up in the residents app.
Elise.
Question for you. We just went through this with our faculty and their feedback on this, and they are super reluctant to write the constructive comments. They're exactly about like being worried about hurting the residents' feelings. It seems to have been more. It's coming to focus more with this assessment system. I guess it's because they're observing something and they're really worried that resident's going to be like sort of crushed if they write something that's constructive. Did you all experience that in your places when you started using this specific assessment? How do you faculty respond to that? Getting more different kinds of constructive feedback.
We're all perfect up here. So I think, you're hitting on a really key challenge in feedback in general that I suspect everyone in this room has struggled with, and I don't think we're any different. We do see more granularity and detail. I think one of the key elements is, have you been able to discuss this with someone initially and get their perspective on it, or are they feeling blindsided by it? And is it very, I observed and here's the data, or you're a bad doctor, just to do gross oversimplifications. But it is an eternal challenge with feedback. I think in general, we're probably more on the positive side, but we have not been without our own individual challenges, or someone's mad about something someone wrote, or upset, offended, hurt.
Go ahead.
We're a little bit opposite. I actually, when we were in New Innovations, had to turn on the function where everything had to be read by me before it got released to the residents, because sometimes I had to massage the message or just fully not send it to the resident and convey things in a very edited version, because the faculty were very free with their negative comments. So that's just our culture, and I think people are not super concerned about that. I think it has actually been even better, again, because these are tagged to individual observed behaviors, because you can say like, hey, I know this was a really chaotic day, the family member was like really, in your face, but here's how you could have done better in that situation. That I think probably from a humanistic standpoint feels like it's not quite as a big deal. And again, just because we have 10 times the number of data points now that we did before. So each one just feels so much less consequential, both to the person giving it as well as to the resident receiving it.
And I think that sort of individual sort of micro nature of it has been key to our messaging too, of like, hey, the best resident could have a rough shift where, I needed help a lot with that airway resuscitation, doesn't matter. And the very worst resident could have a procedure or whatnot that you didn't need to help them at all. They just were doing a good job with something in their wheelhouse. So it's not a grade; it's a individual observation of a specific micro behavior, and I think that sort of helps reset the frame a little bit, because I think otherwise it does become very easy for it to be like, oh, this is a grade, this is how much I like them, this is how good a person they are, that sort of thing.
So I want to shift really fast to what I think are some really important technical issues that are worth thinking about how this has been operationalized. And you heard several of us are using the simple app. Ben's still on paper. We've got other people with multiple homegrown systems. And one of the, I think, key things that this process have done is reduce some of the barriers to actually assessment completion. So do I have to remember my MedHub password that it decides it hates me and I don't actually exist in the system once every 3 months and have to go through a whole reset process? Do I have to work in a clunky system? Does the notification come to my email that I have to go someplace else, or can I just go get a direct notification? So I think really thinking about, as you move toward this system, what are ways that you can really reduce energy of activation for completion of these micro assessments, is regardless of what platform you put it on, is going to be really important. And I'm going to give you a dumb example that to me is huge time saving. I can dictate this using our system. And that means I can dictate it walking down that long hallway from the emergency department to my office, or climbing the stairs out to my car at 2 in the morning, hopefully after I've debriefed with the resident. And it's right there, it's fresh, I don't have to be at a desktop, it's portable, and it can get done. So if you move to a system like this, thinking about how do you reduce barriers, how do you make it easy to get into the system and complete it, I think is going to be critical, whether you're paper or a high-tech app or something in between.
Yeah, particularly if you have multiple sites, whatever system you pick, like the Simple app is great because it's not like tagged to university email or things like that, like our other course management systems are. But like this has been the best thing for us for our other sites to actually provide feedback for our residents as well, because of that really low activation energy. Like everyone at our community sites knows how to open an app, and it's fairly self-explanatory. And both of our community sites have actually tied into compensation as well, that they have to complete a certain number in the year. So I think it's just that really low barrier to entry, that ease of access has been absolutely life-changing in terms of just getting data.
In front.
Is this the only shift assessment you do, is the EPAs, or is there a separate overall shift assessment or evaluation?
Just this.
Yeah.
Yeah.
And we have emphasized to faculty that because these are micro assessments, like if you've got a lot to say, if it was a crazy shift where you had an intubation and some critical care and a sedation, and these are quick and easy enough, do all three. Our paper cards actually are now set up to allow people to put 3 on one card, because we want to emphasize that idea of like, don't spend a great deal of time, don't write the great American novel in the comment card, like just crank out a couple of these real quick and sort of tell us what you saw.
And it's the same for us, and it's a bit of a double-edged sword, because the residents don't always like having a single component of their shift being the thing that's commented on. Let's say that you had a procedure that you did really well, or a resuscitation that went well, and you had something else that, like in your communication, that perhaps was a little bit off during that shift. And if that's the thing that the attending happens to talk about, then the resident's left wondering, well, what about the things that I did really well on this shift? Why didn't you talk about that? And the hope is that because we have a greater volume of assessments overall, that it becomes like that point list painting, where we have many data points across a spectrum from many raters, and that compensates for the fact that on any given shift, you may only get one small discrete data point. But we still favor this approach, because with the great number that we're getting, we think that it really does overall provide us better data.
So we still have both. The option is there for everyone that has a university login, they can still use new innovations. Number one, because our junior office said we have to. And number two, because we have a couple faculty that just can't compartmentalize like this, and they really wanted to be able to do a holistic assessment for the entire shift. And we said that's fine. Like our initial goal was just we need data, because we had terrible data before we started this. I will tell you that I have 2 faculty that routinely do innovations, and everyone else is on this. But the option is there should they decide. The other thing about there's no anonymity in this, it will go straight to the resident. So I do have faculty that still use new innovations to send me private assessment data, particularly around really bad things. So it's nice to have that other option for us because of the way our faculty operates, but I will say it's literally just 2 of my faculty that use it.
Yeah, we also have a Qualtrics where I say if something truly egregious happened today that I need to talk to this resident about within the next 24 to 48 hours, this is where you put it.
And do you make a recommendation for how many per shift?
And I think this is very context specific, but our faculty, basically, if you are general faculty, it's 7 per month. And if you are core faculty, it's 14 per month. We just generally tell people like try and do one, at least one every shift. By and large, like again, I can dictate one of these in 60 seconds, and I'm a pretty verbose person if you haven't noticed. And so like I can do probably a dozen of these walking out to my car. No problem.
So I think that joint shared responsibility between residents and faculty is important. So that instead of just, the observation that you heard about the faculty's commenting on the thing that went not so well, and I don't think that there's a definite trend, but the resident may trigger one and the faculty may trigger one, so that you can have a little bit of hawks, doves, strengths, challenges offsetting each other. I set the record, someone sent me 37 assessments one day. It was early in the development system. It's ruined my numbers for the rest of the year. Generally I find I get more than one from residents, and it actually, I think it also helps to make it very explicit at the end. If you're doing a quick debrief, it's like, so what EPAs do you want me to assess you on today when you send them? And I'll challenge people, give me one you think you hit it out of the park and one where you think you actually want the constructive feedback written down that we talked about, and I'll let them pick. And if they're really dodging me, I can still deploy it. But I think just really engaging with that shared governance in the system is incredibly important.
Question in the back.
So first of all, excellent work on what everyone did in the last several years of bringing EPAs to emergency investment data is phenomenal. I love EPAs. I've studied EPAs for the past several years, and the fact that we're all positive that and now people are getting that here, it's amazing. I'm actually PEDS emergency medicine, and I have the PEDS background as well for the EPAs, and we're actually going to be implementing simple. I actually had a talk with Dr. Carvarelli from University of Michigan for some different topic for procedural eval, but one of the things that's, again, faculty development challenges, because we're getting, and I'm in charge of 15 residencies that come through our Children's Hospital ER in New Orleans. So we have PEDS EPAs, and now we're probably going to have the EM EPAs and the EM residents. How do you tackle that kind of divide? If you have faculty for both, and you have like faculty kind of trained, probably getting trained into both, how do you all tackle that? How do you all have to tackle that?
This might be unique to us, I think, because Deb, she actually works with me. We have actually sat down with our PEM faculty and basically said, similar process, similar-ish enough app. Just think about the different things that you're being asked to observe, and think about the fact that these residents have very different outcomes because they're going to be doing very different things eventually. And what you expect of the PEDS residents may be very different than what you expect of the EM residents. It's really been simple as that. And not to make a pun, but having the simple app actually like being able to show the screenshots of the differences side by side and just do the comparison of like, here's how you would think about this, here's how you would think about this, has been really helpful. And then for PEDS EM, obviously you guys are going to be assessing the fellows. It's going to be a whole nother kind of layer of, these are the EPAs that you are going to be thinking about with this. And I will say on the technical side, that's a whole can of worms, but Simple's been able to try and work through, you're able to change roles, and here's how that works. Okay, I'm going to power through this next little section, mostly because I want to get to the last couple things. We have actually, again, sat down and said, where are our biggest assessment gaps? And the big one, as you guys will probably think about when the ACGME comes to call, is where are my off-service assessments? And so we tackled that a little bit and said, what are the things we need to be able to say that our residents can or can't do based on the time they spend away from us? And have broken it down by rotation. So performing reduction of orthopedic dislocations. These are just some examples, but they're, for critical care, what do they need to know? For ortho, what do they need to know? For, the cardiac ICU, for, your fast track, things like that. And so we have observable practice activities, which are really micro EPAs for each of these different off-service rotations. We have thought long and hard about multi-source feedback and the different sources we want to gather. So nurses, pharmacists, case managers, techs, patients. What is the data we want from them? How are we going to be able to get that? And we're working that into the same app. So being able to have non-users basically just choose their role, have a drop-down menu and say, this is who I am, ortho senior resident versus, nurse in the emergency department, and have the things that they are available to assess available to them. And then there's been a lot of work on EHR data. And Ben, if you want to talk about EHR data all day, come talk to Ben.
We have a presentation at 5.
There you go. And so, we've been able to look at all sorts of different things and pull some of that into our process. And again, I say when you think about the summative entrustment, that's, throwing your kid the keys to the Porsche and saying, you're good, you're ready to go, or you're ready to progress to the next thing. We've been able to inform the decision-making process pretty successfully with all the information that we've been pulling. And this is the next part where I'm going to kind of throw it to you guys. Kind of how has this changed your competency committee process?
We feel that we have actual data to back up our decisions. Because again, I cannot emphasize to you how little assessment data we had before this. Like, shockingly little. One of my former residents is in the audience somewhere, and she can tell you, like, if they got 5 assessments in a year, that was a good thing. So it was a lot of us using our gestalt, our experience, and trying to justify the milestones that way. So that I think has been the biggest thing, is like, we can point to specific data and say, this is what justifies this particular level for this resident on this subcompetency. I think that's the biggest. I would love to get into the data visualization a little bit more. We're not there yet.
Yeah, the specificity, the specificity of this is so powerful. We had, one of our learners has had to go through some remediation and some further work, and having the specific examples that I can pull out and map to each milestone and say, this is why we're assigning you a milestone that's at a specific level, and then being able to talk through the experiences that are tied to that has been really helpful for engaging them on, like, here are the areas that you can discreetly start working on. Here's how we can formulate a plan around this. Whereas previously we would have had a little bit more like hallway conversation, a little bit more gestalt, and it's harder to pinpoint the areas that people can discreetly advance on. I think that's the real power of this system. Because there's such specificity attached to it, you can turn that into action points in a pretty straightforward way.
Yeah, from a diagnostic perspective, it has definitely helped to be able to sit down and say, here's the actual problem, and here's what we actually think we can do about it. All right, I'm going to blow through the data visualization piece. You have the slides available to you. So this is what's coming. Supposedly this month. So you'll be able to see for an individual resident how many assessments they have, which domains they're in, the average involvement rating, the different number of raters for each of the different EPAs. And then you can zero in on a given EPA, look at the average rating, the most recent ones in a scatter plot, and all of the feedback subsequently below that. And then eventually we're going to be getting into predictive analytics, so the predicted entrustment score, the confidence in that entrustment score, and all of those fun things. So again, I think this has given us a great shared mental model. It's helped us with diagnostic assessment and all of these different things. But I want to make sure we get to the other 2 components of CBME. So coaching has been an interesting process for us, and we have actually ended up with probably 3 different models across our pilot sites, which is separate core faculty coaches, APDs as coaches, or a mix of kind of core faculty as competency committee members and coaches. And I want you guys to talk a little bit about, I think this has been one of those things where there's a lot of acceptable variability based on context and kind of things that have worked, just depending upon what it is that works best for your program.
I think inherent in the term coaching is the separation from the act of assessment, or at least acting on that assessment, and providing some degree of neutral reflective space. I think we'd probably fall into the last category that, I think for routine growth and development, most of our residents are really leaning on their APDs for common conversations, but we've particularly found it useful either when that relationship gets strained or there are struggles to intentionally try to make sure that someone has a neutral individual who that is really just there as their advocate and is very intentionally separated from the assessment process, particularly if we're moving into remediation or someone having struggles, even if they haven't moved to that part yet.
Yeah, I mean, I think this has been a fun piece of the puzzle to see. I mean, I agree with Laura's assessment of, coaching is a little bit of a challenge, right, within our space because we don't have anybody who's totally removed from this. So our coaching program has sort of evolved to a place of it's really specifically performance coaching. They really take the outputs from the CCC, these sort of concrete data points that come up because of the, EPAs that people are getting, the comments that they're getting on the EPAs, and really do some goal setting and check in with the residents about their goals once they're set. And it's been really gratifying to see because we have that that picture that we can paint for them. Hey, it looks like you're really making progress. We can see your progression on the milestones or the EPAs that you're getting, and because we can now set these concrete goals and then watch you achieve them. So that's sort of what it's looked like in our setting. Some bumps along the road, certainly, because I think, getting both faculty and residents to understand that both the strengths and limitations of that performance coaching model, and that it's not somebody who's purely a completely separate reflective space for you, has been a little bit of an issue, but I think it's been wonderful overall.
Yeah, and I will say, so just going back a little bit, we have an individualized learning plan that Kevin Scott developed out of Penn and has kind of disseminated amongst our different groups that has been used and adapted by a number of our programs, really talking about, what are your values and your goals? What are your personal and professional goals? What are your career aspirations? And then looking at, every time you meet with your coach, where are the areas that you think you're doing really well that you want to continue to cultivate, and where do you want to see an opportunity for growth? And we do this again after every competency committee meeting where they're meeting with their coach and saying, here's the data that I'm seeing out of the competency committee. Here's how I feel. Here's what I care about. Here are the things that I want to work on, and then getting that 30,000 foot view from their coach as well to kind of synthesize what they want to do to move forward. So I know we are well out of time. I can stick around for a few minutes. I don't know if anybody else can. If you have any questions or if you want to get more involved with this, please do not hesitate to reach out to me or to anyone up here. Sorry, I'm sacrificing all of you. And we would love to have you. And thank you for coming.